Important question about recurrent laryngeal nerve injury. After recurrent laryngeal nerve injury, spontaneous reinnervation of laryngeal muscle is A. Rare and unpredictable, B. Is common and considered the rule rather than exception, C. Is impossible due to lack of neural connections, D. Is always result in full motion recovery. Answer of this question is laryngeal muscle have a strong inherent tendency to reinnervate after injury. However, the recovered motion is usually non-physiological. Some statement on laryngeal paralysis. Most sources of laryngeal nerve injury fall into three broad categories. First is mechanical damage from surgery or trauma. Second is functional compromise due to medical conditions. Third one is idiopathic causes. Laryngeal paralysis is more common in men than the women, reflecting higher incidence of thoracic malignancy in the male. Left vocal fold is affected more often than the right, approximately 60 to 40 ratio, due to greater length and deeper descent of the left recurrent laryngeal nerve into the thorax, making it more vulnerable to the disease and surgical trauma. Iatrogenic injury remains the most frequent cause, with thyroidectomy still being the major source of recurrent laryngeal nerve injury. Other causes are cervical surgeries like parathyroid, anterior cervical spine surgeries, vagal nerve surgeries, and cricopharyngeal myotomy or Jenker diverticulum surgery. Other are thoracic surgeries like pneumonectomy, pulmonary lobectomy, repair of thoracic aortic aneurysm, CABG, aortic valve replacement, esophageal or tracheal surgery. Other surgeries like scalvis, brainstem procedure, other medical causes, central venous catheterization or endotracheal intubation. These are the causes of the laryngeal injury. Means this laryngeal nerve injury, it may be recurrent or external branch of the superior laryngeal nerve. Now some important point about reinnervation in laryngeal paralysis. First is natural tendency for reinnervation. Larynx has a strong inherent propensity for reinnervation following nerve injury. This is the rule rather than any exception of this rule. Both recurrent and superior laryngeal nerve attempt to regenerate after damage, and they always try to regenerate, and this rule does not have any exception. Second is type of reinnervation. Reinnervation may occur either by collateral sprouting from the contralateral intact nerve or by misdirected axonal regeneration from the injured nerve itself. Third one is non-physiological outcome. Although reinnervation restores muscle tone and prevent atrophy, it does not restore normal coordinated movement of the vocal folds. This is because adductor and abductor fibers often reconnect randomly, leading to synkinesia, simultaneously contraction of the opposing muscles because of this mixed connection. Fourth is functional consequences. The reinnervated larynx usually regain a median or paramedian vocal fold position, maintaining adequate airway and improved voice. But true dynamic motion is typically absent because of this mixed reinnervation. Fifth is clinical implication of this reinnervation. This is often non-selective reinnervation explains why many cases of vocal fold paralysis remain immobile yet tonically positioned. Why voice improves without visible movement. It also influences decisions regarding reinnervation surgery and voice therapy. So these are important points. Both human and animal studies have shown that the larynx has a strong propensity for reinnervation, which appears to be the rule rather than any exception of this rule. However, reinnervation of recurrent laryngeal nerve is more problematic than most other peripheral nerves because it carries mixed population of adductor and abductor fibers. Reinnervation is often dysfunctional, does not yield physiological motion. This neural dysfunction extends beyond traditional notion of synkinesis, in which balanced coordination of adductor and abductor fiber were theorized to produce an absence of net vocal hold motion. In fact, dysfunctional reinnervation may also occur when nerve regrowth is appropriately directed but insufficient, which may result in decreased force of contraction, loss of motor unit, increased muscle fatigability, and possible changes in peripheral and central neural organization. Nevertheless, the natural tendency for reinnervation accounts for general trend to voice to improve over time in unilateral paralysis. Because of predominance of adductor fiber, reinnervation tend to restore or preserve muscle bulk and tone, occasionally to the point that phonatory glottic closure is restored and voice is conversational even though there is immobile vocal fold is there. This explanation, well supported by electrophysiological evidence, is probably closer to reality than the notion of gradual contralateral compensation. So, more innervation leading to voice glottic closure rather than the notion of gradual contralateral compensation. So, this explanation is well supported by electrophysiological evidence. So, any damage of recurrent and superior laryngeal nerve always lead to reinnervation. It means this reinnervation is not physiological, but it can maintain the tonicity. Hi guys, some important point about laryngeal reinnervation. Reinnervation. So, laryngeal reinnervation. What happened during thyroid surgery or systemic disease or idiopathic injury of these recurrent or superior laryngeal nerve? So, most common mode of injury of recurrent and superior laryngeal nerve is the thyroid surgery. Thyroid surgery means iatrogenic injury. Iatrogenic injury. Like any injury by anterior neck surgeries like thyroid surgery, parathyroid surgery, thymus surgery, thoracic surgery, CABG, all these can lead to injury of this recurrent laryngeal nerve. And it may be idiopathic injury or systemic disease like diabetes, hypothyroidism may induce this injury to this recurrent laryngeal nerve. But first rule of reinnervation, all nerves supplying larynx have propensity to reinnervate, and they are always reinnervate. So, by any mechanism, these nerve can damage. But all in both human and animal studies by electrophysiological studies, it was found that all nerves which are supplying the larynx always reinnervate and they are always reinnervating. So what does mean, even though what difference between this superior laryngeal nerve or recurrent laryngeal nerve injury which are not going to be functional even though any peripheral nerve What difference between these nerves and other peripheral nerves? They are always not regenerate, and even though they regenerate, there is no any that mixed fibers. But in this recurrent and superior laryngeal nerve, always having mixed fibers. This, especially this recurrent laryngeal nerve. What happens in reinnervation? That adductor and abductor fibers are mixed. So there is not normal functional movement of this vocal fold. So this reinnervation is not proper direction. So mixing of this adductor and abductor fiber lead to abnormal motion of the vocal fold. And sometimes what happen, even though there is no movement of vocal fold, even though they are reinnervate. So in physiological study, it was found these laryngeal nerves always reinnervate and they may not be functional but maintain the tone and bulk of the muscle. But in unilateral injuries, they innervate and having some movement even though there is no movement. So rather than compensation from the opposite side, these maintaining the bulk and tone of the muscles, that's why there is always conversational voice is there in unilateral vocal fold palsy. While in bilateral palsy, their reinnervation is misdirected on both sides. That is not leading to proper conversational voice in bilateral vocal fold palsy. So, by reinnervation, this is not proper reinnervation, it is mixing of the fibers. That's why there is decrease of force of contraction. There is mixing of the tonicity and organization of the central and peripheral fibers. So that's why this reinnervation is misdirected. So important point here is these laryngeal nerve, superior or recurrent laryngeal, anyhow they are damaged, they always regenerate. So during thyroid surgery, we have to preserve them not because of they are going to be loss of function, but because if they damage, they are leading to misdirected reinnervation. So that's why not leading to proper motion of the vocal folds that may maintain the vocal cord function. Another point is these adductor fiber are having capacity to more reinnervation than the abductor fibers. So always there is voice comes while dyspnea continue. So adductor fibers are first to reinnervate. So they may innervate with this, but these adductor fiber in recurrent laryngeal nerve is first to reinnervate. So these 2 points, adductor fiber first to reinnervate, second is any fiber of the laryngeal nerve by any damage, by any mean, is always regenerate. So this is important point and this is given in the Scott Brown, and both animal and human studies are found that these fiber are important for reinnervation. So this is all about laryngeal reinnervation. Thank you so much.